A common question I get from patients is how to pick the right medication. Navigating the options for anxiety can be overwhelming. There is no one-size-fits-all approach because anxiety presents differently in every patient, ranging from chronic, generalized worry to acute physical panic. In today's video, we're breaking down the different types of anxiety medication and their pros and cons. Hi, I'm Dr. Shauna, and I'm a double board certified psychiatrist and anxiety specialist, and you're watching Mental Health Explained. Let's get into it. The first category is SSRIs and SNRIs. Some examples of these are sertraline, escitalopram, venlafaxine, and duloxetine. These are considered first-line treatments, meaning they're the standard of starting point for newly diagnosed patients. These are non-addictive and treat both anxiety and depression concurrently. However, they require consistent daily dosing to maintain steady-state levels in your system. The primary downside is the onset of action. They typically take 4 to 6 weeks to reach full efficacy. Initial side effects can include nausea, headaches, or a temporary increase in jitteriness. Some of these medications are very sensitive to withdrawal, so it is important you try to take them at the same time of day and do not stop abruptly. Always discuss any side effects with your provider before making any changes to your regimen. In children and teens, we monitor closely for any changes in mood or sleep during this induction phase. It is also extremely important to monitor for any worsening of mood, negative thoughts, or suicidal thoughts, especially in children and adolescents and young adults. If this happens, you must contact your prescriber right away or seek immediate medical care. Next is a category called serotonin agonists. An example of this is buspirone. This is a targeted anti-anxiety medication that does not typically cause weight gain or the sexual side effects often associated with SSRIs and SNRIs. It is frequently used as an augmenting agent when primary medication provides only partial relief. It is not an as-needed medication. It must be taken daily, often twice a day, to be effective. For patients with severe panic disorder, buspirone is frequently not potent enough to manage acute surges of adrenaline. Now let's talk about beta blockers. Some examples are propranolol and atenolol. These are used to manage the autonomic physical symptoms of anxiety, such as a racing heart, tremors, and sweating. They are highly effective for performance anxiety and work within 30 to 60 minutes. The main limitation is that they do not treat the cognitive or thinking aspects of anxiety. Furthermore, they are generally contraindicated for patients with certain types of asthma or a very low resting heart rate. Then we have antihistamines. An example of this class is hydroxyzine. These are non-habit forming and are used as a fast-acting alternative to controlled substances. They are particularly useful for pediatric patients or adults where addiction risk or respiratory depression is a concern. The primary drawback is sedation. Many patients experience significant drowsiness or a hangover effect the following day. I recommend taking an initial dose at home to assess how it impacts your alertness. Moving on to mood stabilizers. Some examples used off-label for anxiety are gabapentin and pregabalin. These are anticonvulsants that can calm an overactive nervous system, specifically in patients with significant muscle tension or anxiety-related insomnia. They are often utilized when first-line treatments have failed or as a transition medication. Side effects include dizziness, peripheral edema, or brain fog. From a clinical standpoint, insurance coverage for certain extended-release formulations can be a barrier, though generics are widely available. We also have to discuss benzodiazepines. Some examples are alprazolam, lorazepam, and clonazepam. These are rescue medications that provide near-instant relief for acute panic by enhancing the GABA neurotransmitter. However, I prescribe these with extreme caution. The risk of tolerance and physiological dependence is high. Chronic use can lead to cognitive impairment and makes it difficult for the patient to utilize behavioral coping strategies like CBT. I reserve these for short-term crises or specific triggers such as medical procedures or travel. Abusing benzos is unfortunately very common, and while can provide some relief, it can easily turn into addiction and dependence. Finally, we have interventional treatments such as TMS. TMS is transcranial magnetic stimulation, and it uses electromagnetic pulses to stimulate mood-regulating areas of the brain. It is non-invasive and lacks systemic side effects, but it requires a daily time commitment for several weeks. This is a good option for those who cannot tolerate traditional medication or only have a partial response. My advice, keep a symptom log for the first 14 days of any new treatment. Note the timing of your doses and any physical changes. Always bring a complete list of your current medication and supplements to your appointments to prevent drug-drug interactions. If you found this clinical breakdown helpful, like and subscribe. Remember, you can always contact a mental health professional for more information. I'm Dr. Shauna, and I'll see you next time.